Good evening, ladies and gentlemen, once again to this wonderful platform of science called the Times of Gynecology. The best of any TOG webinar, as we call the best speakers known for their scientific content. So, in short, these are well known and need hardly any introduction, though I will quickly run through the CVs of our well known chief guest and our guest of honors, chairpersons, speakers, and panelists. I am your host, Dr. Niranjan Chavan, live bridging Bharat, supported, and we go live now. Thank you. Well, today we have our chief guest, Dr. Sanjay Gupte. He's a well known figure. We all know he is representing India at the FIGO with the ethics committee being the chair. It's a very big position, sir. We are very honored to have you on this wonderful scientific Sunday on 20th of September 2020. We all know, sir, you were the past president of Foxy, of Dipsy, and of Pune Society. You also represented all us at the Maharashtra Medical Council. Welcome, sir. I would request you to please tell two lines.
Ah.
Yes, sir.
Hey, Niranjan, it's a real pleasure to be here on this TOG webinar, and I'm looking forward to listening to all the wonderful lectures. And it's so nice to see all the friends, on the in front of me. And I'm not going to take much of your time, all because the talks are very important. And let's proceed with the talks. I think that's more important. People's time is very important. Thank you very much for having me here as a chief guest.
Thank you so much, sir. We are honored that you are being there present. Now I call upon Dr. Suchitra Pandit. Madam is a teacher par excellence and she was associated and with me now also in Sion Hospital. After that, she went to another hospital, but presently she is now a consultant in the Department of Obstetric Gynecology, Surya Group of Hospitals in Mumbai. We all know that she has been the MOGS and the Foxy president, the only one who hold a post twice, two posts in 1 year, and she is the chairperson AICC RCOG. Currently, she is the president of ISOPAR. She has got many awards. She is also associated with Justosis, and we also know her most popular program of Kishori Adolescent Empowerment Project, which went in Dharavi, the largest slum area of Asia. Welcome, madam, and I request you to please inspire us with your two lines. Madam, please unmute.
Yeah. Thank you very much, Niranjan, for having me over here for this program on elusive endometriosis and fumbling fibroids. I see a lot of young faces, upcoming faces, and it's very nice to see all of them grow up into budding orators. And it's great that the Maharashtra, IAG committee is taking up this big job of getting so many heads together and imparting knowledge. And I'm sure that the interactive sessions that will follow will be of great benefit to the viewers. And I congratulate all the speakers, and I congratulate you and the TOG series for keeping this very lively activity going on. Thank you very much, Niranjan.
Thank you, madam, for your pearls of wisdom. Now I move on to our guest of honor, and we have with us illuminaries and luminaries from interior of Maharashtra, and I have with us the dean and the head of the department and the professor from Aurangabad, Dr. Kananbala Yelikar. She was the vice president of Foxy 2007, a BC Roy National Awardee. She has the first of its kind in the state of Maharashtra, high dependency unit. And in Corona pandemic time, she is very busy. I know her schedule. And from 5 o'clock in the afternoon till 9, she is on video conferencing with the state government and the central government, trying to improve the best in this Corona pandemic. Madam, I'm very happy that today you have taken your valuable time to be present today. I request you to please speak 2 lines.
Thank you, Dr. Niranjan, and I welcome all of you. And I am really thankful to Dr. Niranjan because in this era of COVID, it's very nice to see Gynec is still alive and people are still doing the work because now because of the pandemic, I mean the whole world is after COVID and non-COVID patients are suffering. So it's a good thing that you people are dealing with non-COVID, and a word of wisdom, I'll say that stay safe because day and out we are hearing about the tragedies of doctors who are treating the COVID patients. So be safe before touching the patient for surgery or before preparing. Please test him for the antigen testing and then only go ahead with the surgery. And wishing all best for this particular webinar, especially the topic of endometriosis. Thank you, Dr. Niranjan, and all the
Thank you so
faculties.
much. Thank you, madam. Please,
Thank
thank
you.
you so much. Now I call upon the next guest of honor. We have Dr. Mandakini Meg. I just received a call. She is busy, held up, stuck up. She will join us soon. She's the chairperson of ICOG and also the vice president of the International MWIA Central Asia, vice president AMWI Central Council. She was also the vice president of Foxy. Thank you, madam, for accepting. We will soon join you. Thank you. Next. Well, we have another luminary and a great person, human being from Nagpur, that is the Orange City of India. She is the medical director of Shrikande Fertility Clinic, chairperson designate ICOG 2020. She is also the past vice chair ICOG, a senior vice president of Foxy, has received Nagpur Ratan Award from Sri Nitin Ji Gadkari. Welcome, madam, and I request you to please inspire us. Kindly unmute.
I'm very happy to see such a vibrant Maharashtra IAG, and as a secretary, Dr. Niranjan Chauhan is really doing a great work by organizing regular webinars. He is updating the members on various latest techniques. And in this COVID era, Niranjan, you have really updated the knowledge of all IAG members about do's and don'ts and what they should do in their OT, what anesthetists should do, what equipments they should do. And as Yedikar madam has rightly said, these are difficult and challenging times, and we should first protect ourselves, and of course we should take all due care of our patients as well. Thank you so much for inviting me here as guest of honor, Niranjan, and all the very best to you in your future endeavors.
Thank you, madam, for your wonderful, inspiring words. And I request you, please be there. Don't leave us. You are going to be there and giving us your pearls of wisdom and your special comments in between. Thank you. Now I call upon our chairperson. So we have wonderful chairpersons. I'm going to introduce them in one go. Dr. Sneha Buyar. She is from Yavatmal. She is presently the chairperson of Study on Female Breast Committee and also the governing council member ICOG 2019-21. Recipient of National Award of Foxy for the outstanding work in rural obstetrics, Dr. Anandibai Joshi Award for the outstanding female doctor of the state by the government of Maharashtra in 2005. I can go on and on. Thank you, madam, being there with us. Can I have the next? Yeah, Dr. Kiran Sarda, madam. She's the president of Solapur Obstetric Gynec Society, practicing obstetrics and gynecology since 1994. Director of Sarda Hospital, and she is representing Solapur today. Welcome, madam. Now I call upon our next vibrant and most dynamic from Central India, Dr. Vaidehi Marathe. I remember when she took her presidential year as of the Nagpur Society, she has started DGO Con, and it is going amazing. Many of them come and visit her every second day. They have these programs. She's the director of Mayer Maternity and Nursing Home, practicing since 24 years, vice president of NARCHI 2018-20, and winner of the MS Signature International Award. Thank you, madam, for joining us today. And lastly, I would like to call the last chairperson today, none other than Dr. Nilima Ardha Thakre. She is a practicing obstetrician and gynecologist at Amravati. She is the president of Amravati Obstetric Gynaec Society, treasurer of that wonderful state AMOX conference which was held in February. We know what the hospitality you have done, madam, and I welcome all of you today to this wonderful platform of TOG. And I hand over the mic to the chairpersons to take over ahead and introduce the speaker. Our first speaker is Dr. Harshad Parasnis. Second is Dr. Pandit Palaskar from Aurangabad. This will be followed by my panel. Well, I hand over the mic to Dr. Sneha Buyar. Thank you so much.
Thank you, Dr. Niranjan. Good evening, respected mentors, especially Dr. Sanjay Gupta, Dr. Suchitra Pandit, Dr. Mandakini Meg, Dr. Kanan, Madam, and dear friend Lakshmi. I welcome you all for this academic session, the first session. The topic is relation of endometriosis to cancer. Actually, and the speaker is Dr. Harshad Parasnis. Can I have his CV, please? Actually, this topic, I just correlate, though there is no trade correlating between endometriosis and cancer. Is president of Pune Obstetrics and Gynaec Society, and he's the associate president and head of Gynaec unit of visiting gynecologists, Medical College and Sassoon Hospital, which happened to be my parent institution too.
We have lost connection with Dr. Sneha Buyar. Dr. Harshad Parasnis is a consultant gynecologic oncologist from Pune. He is a president presently of Pune Obstetric and Gynaec Society, head of the Gynae Oncology Unit and associate professor at Bharati Medical College. I know him since last 25 years. He has written also a textbook along with Dr. Shashank Parudekar, published by Bhalani, and we had read when we were there as postgraduates. Dr. Harshad Parasnis, I welcome you today. He is going to talk something very different today, endometriosis and cancer. The mic is yours.
Thank you, Niranjan. I'll just share the screen. At the outset, thank you, Niranjan, for inviting me for this webinar. I also would like to thank Dr. Gupte sir, Dr. Suchitra Pandit, Dr. Yekar, Dr. Shrikhande, and all the luminaries who are present today for this talk. Thank you very much for being there. My topic today is about endometriosis and malignancy and its current perspective. It was way back in 1690 that the first description of endometriosis was given by Daniel Schron, and this was in Germany. And since then, for next 225 years or 35 years, the next description was given by John Sampson in 1925, when he first said that there is a malignant transformation of endometriosis was suggested by him. Yeah. Malignant transformation of endometriosis was first suggested by Sampson in 1925 as ovarian cancer in endometriosis. A lot of concepts have changed in the last 95 years about endometriosis and cancer, and the way cancer presents and the way endometriosis can actually can look like cancer and vice versa. But we all know that though endometriosis is benign, the it shares cancer-like features with malignancy. It has a mutation profile similar to that of an ovarian cancer, and it has an increased ovarian cancer risk. So today we will try to understand how malignancy develops in endometriosis by an evidence-based perspective. We all know that endometriosis is present in ovarian cancer along with ovarian cancer in say 39% in clear cell cancer or 21% in endometrioid cancers, around 3 to 3% in serous or mucinous ovarian cancers. So the question here that arises here is that was the cancer present right from the beginning, or was it that the endometriosis gave rise to this cancer? So we need to answer few questions as to what is the risk of ovarian cancer in endometriosis and what is the risk of malignant transformation in endometriosis. Kim et al. Actually in 2014 did a meta-analysis. Now it's a huge number of 4,44,000 patients, 15 cohort studies, 20 case control studies. Now this was between 1990 and 2012, where he found that endometriosis actually increases the risk of ovarian cancer. And he also found that it was basically an early stage disease, a disease which was well differentiated, found more in nulliparous women. The type of cancers were endometrioid or clear cell carcinomas, and serous carcinoma was less frequent in endometriosis associated ovarian cancer than endometriosis associated ovarian cancer. It also showed that the progression-free survival was not different. So there was no difference between the malignancy which developed in an endometriosis setting or a non-endometriosis setting. Also, endometriosis associated ovarian cancers had a better overall survival than non-endometriosis ovarian cancer. Now here again I must remind you that they are hormone dependent tumors, and they do really well if you treat them well. And the last and the most important point that this study showed was that endometriosis does not affect the disease progression after the onset of ovarian cancer. The overall risk of ovarian cancer amongst women with endometriosis remains low. It is a relative risk, say around 1.3 to 1.9%. But what we all must remember here is that the lifetime risk of ovarian cancer, which in the general population say is 1 in 100, will increase or will become twice, will become 2 in 100, which is a big jump. And this is one thing that all of us must remember. Now, does this risk which has increased vary with the type of endometriosis? We know there are 3 types of endometriosis: ovarian endometriomas, peritoneal endometriosis, and deep infiltrating endometriosis. And to answer this, a study was done, which is a Finnish study, which was again a huge study, 49,000 cases or 50,000 cases of endometriosis. Imagine such a huge study, a population-based study. This was done, and this showed that it was ovarian endometriosis had the highest chance of having ovarian cancer rather than peritoneal endometriosis or deep infiltrating endometriosis. And that too, this can occur 5 to 10 years after the index surgery was done. Again, so that means these patients do need a long follow-up if the endometriomas are kept back and treated conservatively. Clinicopathological characteristics of these of ovarian cancer when they are seen with endometriosis. Now here, these patients tend to be younger, they tend to be diagnosed at an earlier stage, they are low-grade lesions, and therefore they do better, have a better survival, are basically endometrioid or clear cell subtypes. So now, if you have an endometriotic cyst, how long does it take for these endometriotic cysts to become malignant? Now this is again a billion-dollar question which is yet to be answered, because there are a lot of studies taking place all over the world. The Canadian study, the Japanese study, and all of them actually agree on the fact that they are more likely to occur in late 40s. If you have a endometriotic cyst then the chances of it becoming malignant will be more in late 40s than after menopause. After menopause, the incidence does not increase, because that again defies the fact that what we have always we have been thinking of, that if you keep the endometriomas in the postmenopausal phase, they would go and the chance of becoming malignancy would be more. No, at least the statistics don't show so. What statistics shows is that women with endometrioid cysts are 9 times more likely to have ovarian cancer than any healthy women. So let's understand the pathogenesis and what changes have taken place in the pathogenesis over these last few years. We all know about the natural course of endometriosis, that there is an ectopic tissue which is implanted, which starts bleeding, it leads to inflammation, it causes fibrin deposition, adhesions, and finally a scar formation, because of which there is distortion of peritoneal surface. Now, this course of endometriosis is known to all of us, but sometimes when you have a genetic predisposition, this inflammation and microenvironment which is conducive would give rise to endometriomas or cyst, and this cyst can later on go ahead and become endometrioid carcinomas. Here the concept of precursor lesion has now cropped up. Now this precursor lesion which Amy Dawson has put up is where she says that if there is an implantation of endometrial tissue and if there are molecular aberrations, then you will have something called as a atypical endometriosis, which will give rise to cancer later on. Now, atypical endometriosis is found in 60% of cases of endometriosis in ovarian cancer. Now, the thought process that most of the pathologists have here is they are trying to extrapolate what we are seeing in cervical cancer and in endometrial cancer, that you are trying to get some precursor lesion to the malignancy. And this has been proposed as one of the important milestones, that a typical endometriosis will be seen in these patients who go ahead to later on become ovarian cancer. The problem here is that atypical endometriosis, the definition and the identification is still not uniformly being followed. So coming back again to pathogenesis, as we rightly said just now, the normal endometrium at abnormal places goes ahead and becomes endometriosis. Then if you have the environmental factors, angiogenesis takes place, oxidative stress occurs, there is an immunological dysfunction that occurs, and with genetic alterations you will have atypical endometriosis. If your genetics supports further changes in that environment, then you finally land up into endometriosis associated ovarian cancer. So now we have two clear-cut separate pathways that have been identified. The first pathway is the one which is called as type 1 pathway, which is what has been our conventional teaching, that you have incessant ovulation, which leads to tumorigenesis, genic transformation, that is you have invagination of the tissue inside the endometrial on the ovary to form an endometriotic cyst. This endometriotic cyst over a period of time, because of inflammation and continuous changes that occur at the microcellular level, will give rise to low malignant potential cancers, and this would go ahead and then give rise to low grade serous endometrioid or clear cell carcinoma. Now this is the path which we already know. This is one path. But the second path which has now come up, which is also called as the dualistic model of ovarian carcinogenesis. This is the type 2 pathway, where the fimbria, fallopian tube fimbria, will actually harbor the cells, that is the serous tubal intraepithelial cancer cells. Now these cells will actually be shed from the fimbrial end. They will actually micrometastasize in the ovary, and then because of because of, again, if you are genetically unstable, then only if the P53 is going to be active there, then these are the patients where you will have a high grade serous carcinoma. So two clear cut different pathological pathways have been defined, and because of that you have two different types of tumors, because their behavior is going to be totally different. If you have type 1 tumor, it is going to be arising from endometriosis. It will be a low grade serous tumors, endometrioid, clear cell, basically an indolent tumor, remaining indolent for a long period of time. So diagnosed at stage 1 and will present as with pain as the primary symptoms, whether it be dysmenorrhea, dyspareunia, or even with painful bowel movements. As against that, type 2 is where you are going to have tumors which are coming from the tubal epithelium, aggressive tumors, high grade tumors, advanced stage of diagnosis, and as we all know, this is the typical tumor that we all say as ovarian cancer, which is picked up at as an advanced stage, say in 70 to 75% of the times. And here you will see the P53 mutations will be seen. Now, one more important point apart from just the etiopathologist type is that it has also got to do with the tumor behavior. Your type 1 tumors are not going to be as responsive to chemotherapy as type 2 tumors. Type 2 tumors are going to be very well responsive to paclitaxel, which is our conventional standard of care chemotherapy. So finally, what remains with us is that let us try to identify the risk factors for endometriosis associated ovarian cancer, because they're going to be long-standing endometriomas. So first is a long-standing endometriosis diagnosed at an earlier age, or endometriosis associated with infertility and infertility treatment, or if it is a ovarian endometriomas. These are the tumors, or these are the risk factors that we must be at the watch out for. Now, do we have any screening or diagnostic opportunities that are going to be available for us practitioners in dealing with these patients with endometriosis? So, as we rightly said, not everybody who has an endometrioma will land up into endometrioid cancer. So, genetics is very important. But currently, there is no sufficient data to recommend mutation screening tests in patients with endometriosis. Similarly, CA125 is again one of the markers that has been used rampantly for ovarian cancer, but also for endometriosis. Now here CA125 is a poor screening modality for endometriosis associated ovarian cancer. Here you will find that CA125 levels are lower as compared to non-EOCs. And also, it is not a reliable marker for diagnosis. It is a good marker for prognosis. So we move on to imaging methods. Can we use an imaging method? Yes. Transvaginal sonography will again show a hypoechoic component, and then inside that homogeneous hypoechoic area you can see certain mural that can be seen, their features that can be seen. Now you can put in color there, and in color Doppler you will see increased vascularity in power Doppler settings. Same can be confirmed by doing an MRI, where you will visualize the endometriomas and detect the malignant transform. So well nicely seen in this MRI plate, where you can see that there is a growth inside the cyst, and this growth is actually a malignant transformation of endometrioma. Now, how do you manage these patients? Let's come to first screening. Routine screening for ovarian cancer in endometriosis is not recommended. Now, this recommendation has come from the World Endometriosis Society as well as ISHRE. Now, if you have a patient diagnosed as endometriosis associated ovarian cancer, how do we proceed? All of them merit a comprehensive surgical staging as for any other epithelial ovarian cancer. Fertility sparing surgery can be done in a select subset where you have a stage 1A grade 1 tumor, where mind you need again to go ahead and do the comprehensive surgical staging, which again includes all the gamut of omentectomy, the lymph node dissections, and the random peritoneal biopsies, peritoneal fluid cytologies. All these have to be done. After the patient has completed her childbearing, you would allow her childbearing to be over, and then completion surgery has to be done, because you again have a 9% chance of recurrence. So completion surgery is necessary. Again, here a word of caution: if you have a low grade tumor, they do not respond well to frontline chemotherapy as do the high grade tumors. Like the type 1 is not going to be and type 2, the same difference that I was talking of. So optimal debulking surgery with minimal residual tumor is the best predictor of survival, and so we must aim at a good surgical job if we are doing at whenever time we have to do it. So what preventive measures can be offered to these patients of endometriosis so that they don't land up into ovarian cancer? The age-old known fact is that OC pills, when used for 5 years, preventing ovulation for so long period, would actually reduce the risk of ovarian cancer by nearly 20 to 30%. Same holds true with tubal ligation. But most important is that surgical resection, that is, if you remove all the endometriotic implants and the tissue, now this remains the most effective strategy for prevention of endometriosis associated ovarian cancer. Again, here studies have been done, huge national studies, study done in Sweden. Imagine the study which has been done from 1969 to 2007. Here again, it showed that lifetime risk of ovarian cancer for women with endometriosis in Sweden was 1.5%, and with ovarian endometriosis it was 2%, the same that we talked of in the beginning of the talk. But what is important to note here is that if you remove all the surgically remove all the endometriotic implants or endometriotic tissue, then you have a risk reduction of 30%. But if you remove, apart from removing that the endometriosis implants, if you also remove the affected ovary, the risk reduction is to the tune of 81%, which is again a huge reduction that you can get here. So friends, to summarize, the lifetime risk of ovarian cancer among women with endometriosis is 1.8%. Endometriosis associated ovarian cancer has multifactorial etiology with mutations as a cause and or effect. The dualistic model of ovarian carcinogenesis has clinical relevance. Endometriosis associated ovarian cancer is early stage low grade ovarian cancer, either endometrioid or clear state, and has a good prognosis. Imaging can help in early diagnosis of such ovarian cancers, and again, most important is that surgical resection appears to be the most effective preventive strategy in these ovarian cancers. So the future research that needs to be directed is to understand the genomic and the immunological pathways of endometriosis, and to develop highly sensitive and specific novel molecular biomarkers to identify which patients of endometriosis would actually finally land up with ovarian cancer. Thank you once again, Niranjan, for inviting me, and thank you for a patient hearing.
Thank you.
Hello. Am I audible?
Yes.
Hello.
Yes.
Hello. Thank you, Dr. Harshad Parasni sir, for excellent talk showing relation between endometriosis and ovarian cancer. It was very interesting to listen from you. There is definitely a relation between endometriosis and ovarian cancer. And one thing we should.
Your voice is echoing because you are switched on from two devices. Remove one device.
Okay. Just. Hello. Now it is okay. Is it?
Your two devices are on. You
Log out. Log out from one device.
Log out from one device. Yeah.
Hello.
Yeah.
I was taking help of mobile if net failure occurs with laptop, no? So that was a problem. Sorry.
Thank you very much for excellent talk, Dr. Harshit Parasinis. You have shown very effectively the relation between endometriosis and ovarian cancer. It is having about 1.9%, you said. And the very important thing I suggest that to take home message is that we should do the long follow-up of endometriosis cases, especially when it is when endometriosis is long-standing and at early age and with infertility. Thank you very much for excellent talk. Thank you once again. Hello.
Yes.
Over to next chairperson.
Dr. Nilima, can you please introduce Dr. Pandit Palaskar, sir?
Sure, sir. Good evening, everybody. Dr. Pandit Palaskar, he's a
Yes,
gynecological.
Dr. Nilima, please go ahead.
Yes, sir. Dr. Pandit Palaskar is a gynecological endoscopic surgeon and IVF specialist, director of Endo World
Dr.
Hospital.
Nilima, your voice cannot be heard. Can you please adjust your audio with a computer audio?
We can hear, sir.
Yeah, sir. I am audible, I think.
We can hear you, Nilima.
Yes, clearly heard. No problem.
Dr. Pandit Palaskar is a gynecological endoscopic surgeon and IVF specialist, director Endo World Hospital, Aurangabad. He is the president Aurangabad OBGY Society, joint secretary Indian Association of Gynec Endoscopies, invited as operating faculty and guest speaker at national and international conferences all over India and abroad, published papers in national and international journals. His center is recognized by FOXY and IH for training in endoscopy, infertility. He has trained more than 800 gynecologists from India and abroad. So I invite Dr. Pandit Palaskar to please deliver his lecture.
Thank you very much, Dr. Nilima, for your kind introduction. Thank you so much, Dr. Niranjan and organizers for giving me this opportunity to talk on favorite subject.
Sir, your voice is not audible. I request you to please speak a bit louder.
Now I am audible?
Yes. Pandit, you will have to just talk a little louder.
Okay. So thank you so
Day
much.
before yesterday, your voice was very, very clear. I don't know. Today, it seems to be muffled.
Okay. I'll try to be loud. I'll be talking on the role of laparoscopic surgery for the management of the uterovaginal prolapse. Now the voice is okay?
Yes, 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 please.
As it is rightly said, the discovery consists of seeing what everybody has seen and thinking what nobody has thought. And that has been perfectly applied to the management of the uterovaginal prolapse. Everybody of us know it is caused by the defect in the supports of the uterus. There is a weakening of the collagen and associated factors during labor or maybe congenital. It leads to the prolapse. It is associated with multiple problems, sometimes with infertility and difficulties with intercourse. And nowadays we know very well this prolapse is managed by the laparoscopy. These are the various prolapse surgeries that can be done for the management of the uterovaginal prolapse. Our Indian gynecologists, they have contributed a lot to the development of these sling surgery, chirurgical sling surgeries done with various modification. We can do sacral colpopexy for vault prolapse, vault suspension with uterosacrals, aldoplasty can be done, birch can be done for the SUI and paravaginal defect when there is a defect in the paravagina. Now we'll see these sling surgeries for the management of the prolapse in the young patient. We'll see the sacrocervicopexy, that is commonly called as chirurgical sling surgery, and it is the most strongest and durable correction of the uterine prolapse. And it is indicated for the patient who is desirous to have a child in the future, who are young and they are sexually active, patients with recurrent prolapse, patients with connective tissue weakness or history of multiple hernias, and patients with chronic increases in the intra-abdominal pressures like patients with chronic bronchitis, asthma, and chronic constipation. So these are the candidates for the chirurgical sling surgery. It has many advantages over the other slings, like it is more anatomical and physiological. There is no it maintains the vaginal axis, that is of posterior. It doesn't cause rotation of the tissue planes. There is a preservation of the adequate vaginal length. Recurrence rate is low with this surgery, and mesh erosion rate is less if it is done properly. These are the various reviews in the journal, which also suggests that laparoscopic sacrocervicopexy is the first line in the management of the young prolapse. This is another paper which also shows laparoscopic sacrocervicopexy is an effective option for the patient with pelvic organ prolapse who want to preserve their uterus. This is a Sirotker sling surgery. We'll see the video. You can see in this patient, this is a third degree uterine prolapse. You can see the cervix is completely lying outside the vagina. Now, after insertion of the laparoscope, we see the anatomy of the sacrum and the posterior wall of the pelvis. Here you can see the sacral promontory, you can see the common iliac and bifurcation of the common iliac into internal iliac and the external iliac. To start with, the peritoneum or the sacral promontory is open to enter the presacral space, and you can see the anterior longitudinal ligament here. Now we have in this case we are showing you the bilateral Sirotker sling surgery, and then we'll see the modification wherein in some cases you may not be able to do the left-sided dissection. In this case, we are using the Marcelin tape, which is 30 by 30 centimeter by 5 mm. The first bite is taken through the anterior longitudinal ligament or the sacral promontory. Take good bite that so that there will not be the suture will not get cut through. And now this tape is replacing the uterosacral ligaments. The needle is passed subperitoneally along the right uterosacral ligament, taking care that you are not injuring the ureter, which is just lying lateral to the uterosacral ligament, and also the internal iliac and its branches. You can completely open the tract from the sacral promontory through the posterior surface of the uterus, but just to be minimally invasive and to prevent the post-operative adhesions, we are passing this tape subperitoneally with making 2 or 3 buttonholes for the easy passage of this tape. Now this Marcelin tape is fixed on the posterior surface of the uterus. Take deep bites, take at least 2 bites so that the grip on the posterior surface of the uterus is firm and it will not get cut through. Now the passage of the tape on the left side is not so easy because there is a sigmoid lying on the left side. So here you have to make the psoas pulley. This is a dissection on the left lateral, left pelvic brim. You can see the external iliac, external iliac, external iliac vessels, and the genitofemoral nerve. And you can see the psoas tendon. After identifying the genitofemoral nerve, one of the instrument like Maryland or needle holder is passed below this psoas muscle, and another Marcelin tape is taken below this psoas muscle to make a pulley, so that this pulley will keep the tape away from compressing the sigmoid colon. This is how we make the psoas pulley. This pulley has to be loose. It should not cause compression of this muscle. Pass this tape completely through the belly of the muscle. It should not pass through the substance of the muscle. Otherwise, patient can have pain during the post-operative period while she is walking or running. Now the left side of this sling is also brought in the reverse direction from uterus to the pelvic brim, subperitoneally. Again, here if you have difficulty, you can make the complete tract open. Now you can see the tape is passing through this psoas pulley on the left side. Okay, this is how the psoas pulley function, and this pulley will avoid the compression of the sigmoid by this tape. Now the needle holder is passed through in the pre-sacral space from right side to the left side, and this tape is brought below the rectum, below the rectosigmoid or the sacral promontory. And then after adjusting the traction on the both arms of the tape is tied over the sacral promontory. If again one bite is taken through the anterior longitudinal ligament, adjust the traction and then tie the 2 ends. Here again, at each stage, we take double precautions. Even we have passed the tape twice through the substance of the posterior surface of cervix and uterus. Another delay, this non-observable suture material, that is ethibond, is passed through the tape and through the substance of the uterus, so that the attachment is firm and there is a less chance of failure. Now, remember, whenever you are putting this foreign material into the peritoneal cavity like mesh or tape, it has to be extra peritonized. Otherwise, any intraperitoneal structures like omentum or bowel can get adherent to this meshes, and there will be post-operative uh, bowel obstruction. Now here we are adjusting the traction over the uterus. You can see there is at least 4 centimeter space is there between and the pouch of the Douglas between the posterior surface of the uterus and anterior surface of the rectum, so that there is enough space for the movement of the rectum during the defecation, because during this procedure the rectum will expand and retract, and there has to be adequate space there for its function. Now here you can see we are tying the both ends of the marceline tape with one more non-observable suture material. Take care that your stitches, they don't pass through the intervertebral discs. Your sutures should pass over the body of the vertebra, not through the intervertebral disc. Otherwise, patient can land into the discitis. And then the extraperitonize the mesh. You can see this is the final picture. You can see the uterosacral ligaments on the both sides. They have been replaced by this artificial mesh, that is marceline tape. There is adequate space is there for the movement of the rectum and the uterus, and there is no problem in the post-operative period. At the end of the surgery, you can see the cervix which was lying outside has gone inside completely in the vaginal environment, and the patient can have the normal vital function. Now, this is a modification of the bilateral pseudocon sling surgery. It is also called as a Sunawala's modification. Here, you have seen that on the left side, the dissection is quite difficult, making the pulley and passing the tape below the rectosigmoid. It can be difficult for the newcomer. So here, you can do only right-sided dissection. So initial steps are just duplication. You have to open the this pre-sacral space by lifting the peritoneum. Identify the pre-sacral vessels. You can see this is a hypogastric nerve, which is clearly seen in this case, which is lying on the left side. So you have to retract this hypogastric nerve so that it will not come in the your bite. Now in this case, we are using the macroporous mesh, that is pore with more than 50 micrometer holes. In previous case, that was with marceline tape, and this is with the macroporous mesh, that is Prolene soft mesh. Here the lower end of the mesh is after creating the space on the right side, the mesh is fixed on the posterior aspect of the uterus at the level of the internal os, where the uterosacral is attached naturally. Here also we are replacing the uterosacral with the mesh. 2 to 3 bites are taken on the posterior aspect, deep bite, so that there is no slippage of the mesh. Otherwise it will cause necrosis. Then the peritoneum is the mesh is extra peritonized by taking continuous or interrupted sutures, and now the mesh is fixed to the anterior longitudinal ligament or the sacral promontory. What we have found in our study that in some patients they can land into the backache. So what we are doing now, we are fixing the mesh as much possible below the sacral promontory, so the chances of backache is reduced. After putting 2 sutures through the anterior longitudinal ligament, and after adjusting the tension, the sutures, they are passed through this mesh and the mesh is tied. Remember that all this is like a hernia surgery. So principle of hernia or fistula surgery is should be tension free. There should not be any tension on the suture line or on the mesh. So it has to be done tension free. And you can see this is the final picture. The cervix has gone into the its original level. And remember, these cervix, they are hypertrophic. Once they go inside the vaginal environment, they get lubrication and moisturization. And with passage of time, this hypertrophic tissue, it goes to its normal size, maybe in the next 3 to 6 months. This video is showing you the presacral bleeding. You have to remember that in many patients there will be the vessels or the sacral promontory, And one peculiar feature of these vessels is these are perforating vessels. They pass the veins, they pass to the vertebra, and when you puncture, there can be bleeding like this. So in this patient, while passing the needle through the anterior longitudinal ligament, one of the perforating vessels got punctured, and you can see there is a profuse bleeding. So what it is, it's not very easy to coagulate these vessels because they retract, and only thing that works is the pressure. So after clearing the this operative field by doing suction, you have to identify from which point the blood is coming, and then if you can see the spurter, you can coagulate. Otherwise, give pressure. Here I am giving pressure with the suction cannula so that you can see the bleeding has stopped. So these pre-sacral vessels, they are very they retract immediately. So you have to apply pressure with the suction or whatever instrument you have, and then clear the operative field by doing suction. If you can see the spurter, you can coagulate. Otherwise, give pressure for 3 to 5 minutes, and usually the bleeding stops. Here you can see the amount of bleeding has stopped, but it still there is some oozing is there. So what we have done is apply the pressure with the peritoneum and the rectosigmoid, and the bleeding usually stops. And then once you are sure the bleeding has stopped, then you can continue the rest of the procedure. Now this is a new coming surgery, that is pectopexy. Because in some patients there can be difficulty, so you should have other alternative option, pectopexy. Here we are fixing the mesh to the bilateral pectineal ligament. The bladder is dissected, and you have to do the dissection laterally over the lateral pelvic wall, in between the round ligament and the obliterated umbilical ligament to expose the this pectineal ligament. Here you can see the corona mortis, which is the junction between the external iliac and the internal iliac vein. Same dissection is done on the left side. You can cut the tissue slowly, and you can see this white glistening ligament, and the rest of the bladder dissection is done. Here the mesh is attached to the entire surface of the cervix at the level of the isthmus, and laterally to the pectineal ligament. This is a relatively easy surgery as compared to the Sirotko sling surgery, and you will really differentiate between the advantages and the disadvantages of two surgeries. Here we are using the microporous mesh. Microporous mesh is the mesh which has a pore size more than 50 micrometer. The mesh is attached by taking 3 or 4 sutures on the anterior aspect of the cervix. Take deep bites, so the attachment will be firm and there is no recurrence after surgery. This is a non-observable suture material. You can use this Ethibond or you can use Prolene also. Serials 3 or 4 sutures, they are taken to fix the mesh anteriorly, and laterally the mesh will be attached to the pectineal ligament on the both sides. So this is how the mesh will be attached. And always remember, there should not be any tension on this sling. It should be completely tension free. After adjusting the tension, you have to fix the mesh. You can see the firm bite. This surgery we have recently started, and we have really realized this iliopectineal ligament is very strong support, and maybe we are studying the results, and let's see how it works. So this surgery is relatively easier as compared to the posterior surgery, because the vital it's easy to dissect the lateral planes. There are no big vessels around. After passing the suture through the pectineal ligament, you can put 2 to 3 sutures on each side, then adjust the traction, and always extraperitonize the mesh. The mesh is extraperitonize here. Any foreign body, either it is mesh or muslin tape, it should not come in contact with the interperitoneal structures. Otherwise, the patient can have the intestinal obstruction. This is how the mesh is extraperitonized, and this patient, they can have a normal outcome in the post-operative period. So as compared to the other surgeries, the sacrocervicopexy, that is chirurgical surgery, has success rate of around 90 to 96%. But problem is that there can be mesh erosion in the range of 1 to 8%, and it has not yet compared with the open sacrocervicopexy. These are various advantages of sling surgery to the patient. Over the open surgery, it avoids the large incision, short hospital stay, reduction in the wound complication, and it is cosmetic. Early mobilization can be there, early discharge, early resumption to the work, and less adhesion formation. These surgeries, they are advantageous to the surgeon also. I remember when we learned this procedure during PG days, it's very difficult to reach the deep pelvic spaces on the posterior aspect of the uterus, but in laparoscopy, there is good magnification, improved visualization, more precise, accurate surgery is possible, and you can work into the with ease in the depth in the pelvis. These are advantages to the society, minimizes the burden on the hospital, elevate the problems of rising hospital costs, and reduction in the number of the hospital acquired infection. This is a study which shows these surgeries, they give quick recovery, reduction in the adhesion formation, which is beneficial to the patient. This is our experience of the sling surgeries. We do these various surgeries very frequently. And let me tell you that doing sling surgery is not a contraindication for vaginal deliveries. This patient, if other obstetric parameters are good, you can give normal trial of normal delivery. Only avoid difficult labors. You can shut down the second stage of the labor by giving a liver episiotomy and applying vacuums or outlet forces. But nowadays, most of the gynecologists, they are not comfortable doing delivery of these sling surgeries. Also, section can be done. This patient, we had a complication like lumbosacral discitis, backache, and recurrence. And let's see how we can manage these complications. So these are the complications of the posterior surgery like backache, lumbosacral discitis. There can be mesh erosion, mesh infection can be there, or there can be recurrence. So goal of the medicine is not just to prolong the life, but we should improve the quality of the life, and this has to be the aim of the any surgery to the patient. So how we can manage the complication? Backache, usually this patient, they are managed by reassurance, rest, and analgesics. When there can be mesh erosion into the vagina, and this is managed by cutting the eroded mesh and trim the mesh through the vagina. You have to take the patient in OT with good exposure. You have to trim and cut the vagina, the mesh which has been eroded, give good antibiotic coverage. And recurrence, if is there, it can be managed by doing the bilateral surgery, or you can do alternative surgery. So mesh erosion is a big problem, and there is always dilemma whether we should use or should not use the mesh, but we have to individualize the selection of the surgery, and this has to be explained to the patient that there is a 1% chance of mesh erosion in the preoperative workup. This is a Cochrane database systemic review which suggests that surgical management for the pelvic organ prolapse, the sacral colpopexy is still the gold standard for the management of the prolapse for women who are desirous to conserve the reproductive function. So how we can prevent the complication? We have to do the proper preoperative workup, counsel the patient, know the defect properly. All the defects, they have to be examined and repaired. So repaired in the same setting, so that patient will not have the recurrence. We should have the good surgical knowledge of the anatomy. Strict asepsis has to be there, because these meshes, they have the chance of getting infected, and strict asepsis has to be maintained. The instrument should be autoclaved, or they should be disposable, and always keep the mesh above the fascia to prevent the chances of mesh erosion. So to conclude, sacrocervicopexy is the choice of surgery for the patients with uterine prolapse who want to conserve their reproductive function. Various modifications of the chirurgical sling surgery can be performed to simplify the surgery if you are not used to the bilateral chirurgical sling surgery. And the choice of the surgery depends on the patient's profile and surgeon's experience. Adequate precautions should be taken to prevent the complications. So thank you so much for patient hearing. Once again, thank you, Dr. Niranjan and the team for giving me this opportunity. Thank you so much.
Thank you, sir, for the wonderful talk. Your demonstration of the videos and explanation was too good. one question is there for you from Dr. Manjushri book, that will pectoplasty complicate the cesarean section?
No, madam. Usually, in pectopexy, the mesh is attached over the isthmus, and it is there is no interference of this mesh when you are doing the cesarean section, because during the pregnancy, the upper uterine segment and lower uterine segment expands, and the mesh lies at the lower level. There is no need to remove that mesh. It will be lifelong.
Thank you, sir. Over to Niranjan, sir.
Request Dr. Nilima to continue.
Yes, sir. Pardon, sir.
Request Dr. Nilima to continue. Dr. Niranjan has dropped out.
Okay. Actually, I think so. Sneha ma'am can continue, because I was not aware of the program actually today. I request.
Shall we start with the panel discussion?
Yeah, I think so. Niranjan sir is there. So you can start the rest. Niranjan sir, you have to unmute yourself.
Yeah, hello.
Yes,
Yeah,
sir.
I think wonderful. Actually, my connection got lost, so we are in that technical glitch and hitch issue. So wonderful lecture of Harshad and Pandit Palaskar sir. Dr. Nilima, did you ask sir one that question?
Yes, sir. He has answered already.
सरांना विचारला ना तुम्ही?
हो, विचारलं सर.
Okay, okay,
सरांनी
okay.
आन्सर
Thank
पण
you.
केलेला आहे. We have
Okay,
to
okay.
move ahead now. Yes, sir.
Okay, fine. So I think it's all done. Dr. Sanjay Gupta sir is there. Suchitra Pandit madam, I wish that you can comment on these two lectures. Madam, if you are there. In the meantime, I will just share my screen.
So panel introduction.
हाँ, panel introduction जरा तो screen share. I have to download. एक minute. Just one minute. I have to download. आज का PPT कहाँ गया? सना. Sana, can you share the panelist and then share the screen? Yeah. Thank you so much. I welcome Dr. Sandesh Kade. He is the team member of the first uterine transplant of India and the first laparoscopic uterine transplant of the world. He also goes to the Abu Dhabi Bahrain International Hospital, visiting endoscopic surgeon to the busiest IVF center. He also has visiting laparoscopic surgeon to Kenya, Bangladesh, Nigeria, and has got training of the TLH workshops at various cities of India. I welcome also now the next panelist who is there with us. Next. Dr. Gurpreet Kaur. He is the secretary of Aurangabad Obstetric Gynec Society and is presently the assistant professor at CAS MMMSS Institute, Aurangabad. Next. I call upon Dr. Rohidas Sawan. He is a unit head and also has a teaching experience of 24 years in clinical and teaching. He is a founder secretary of Yavatmal Obstetric and Gynecological Society, past president of Yavatmal Society, past president of IMA AMS, and past superintendent at Sri VNGMC. He is also the examiner of MUHS and he was attached to a medical college. Next. Dr. Manjushri Boob. She is a very live and vibrant member of Amravati Obstetric Gynec Society, a past president of OBGY Amravati Society, has taken numerous training in from France, in Nauroji Wadia, Chennai, Mediscan, Apollo Hospital, Infertility, France, Germany, and at Sunrise Hospital. Always passionate to get more of learning, and also has got Vigyan Vardhan Award of Foxy. She has also been a faculty at FIGO, and she has worked as an office bearer of treasurer also in Amravati. Welcome, madam. So, Sana, I request you to please share the slides of the panel and the videos. Well, this question can be taken by anyone, and I request you to will keep this question open. A 22-year-old female presented with pain in lower abdomen and right side of the pelvis, especially during periods. Her periods were early and profuse, with severe pain in the lower abdomen, which goes to back. She is feeling excessive heaviness in the uterine region. The patient has had 3 abortions between 3 and 6 months in pregnancy. Next. So, what is your diagnostic approach and management? Well, on ultrasound, she shows posterior wall fibroid 4 into 6 into 5 centimeters in dimension. I request Dr. Manjushri Bhu to start this case.
So she is a case of fibroid, posterior wall fibroid, along with a recurrent abortion that was mid-trimester abortion, and again she has a dysmenorrhea and menorrhagia. So a symptomatic fibroid with a pregnancy losses. Definitely she has to undergo a myomectomy, lap myomectomy. But before that also, we at the same time we can have her tubal evaluation and infertility evaluation at the same sitting, and then go ahead with a lap myomectomy.
Any opinion to be given by the esteemed panelists who are there with us today? Would you still go ahead with the lap myomectomy? Sana, can you show the video? Yeah. So I request Dr. Manjushri Bhu to please go ahead. So mute the voice. So
yeah, it's a hysteroscopy picture, and hysteroscopically you can see ostia and endometrium appears like nice, and cavity is good. And laparoscopically, like first a tubal patency has to be done before myomectomy, and both the tubes are patent. Yeah, left I could see methylene blue, and even right. And posterior wall you can see bulge. Vasopressin has been injected into the fibroid to have a clear field, and a procedure of myomectomy is started. There is a coagulation on the surface of fibroid, which is then followed by dissection of capsule of fibroid, and now it is being separated. Whole of the fibroid is dissected out, and now the fibroid is almost moving out of bed, almost. With myoma screw, we can give traction so that it can get enucleated very easily without trauma to the surrounding structure and tearing of surrounding tissues. After that, at the best, sometimes you find very vascular pedicles at the end or base, which you can coagulate. Just don't give undue traction at the base. Otherwise, whole bed will be full of vessels and vascular bleeding. So avoid that. After coagulation, you can park the fibroid, and then suturing of suture can be done by barbed suture, V-lock sutures. And in suturing, most important thing is you have to obliterate the bed. There should not be hematoma. Hematoma may make the bed very loose, and in future there could be chances of rupture of uterus also with that. So suturing is art. sorry, excuse me. Second, it is a posterior wall fibroid. It's always better to cover with adhesion barrier. So interseat can be used once a proper suturing and obliteration of bed has been done. VLOC has made myomectomies better, surgically easy and better procedures. This fibroid can be removed by morcellating. There are various tissue retrieval things we can do. We can have in bag or we can remove through vagina, whatever way is comfortable. I think it is a small 5 centimeters, so it was easy. Yeah, interseat has come now, which is going to cover the suture line. With VLOC, if we cover with interseat, like chances of adhesion to colon or surrounding momentum, this all to the spikes of VLOC will not be there.
Yes, madam.
Yeah.
Wonderfully explained. I think it's very important that we obliterate the dead space and see that there is no hematoma formation. You have to see the bed has to be totally coagulated, and you have to see that hemostasis is very well achieved. Because if you don't do, there is a hematoma. Madam, in case if the endometrium is open, then what precautions can be taken in such situation?
Ideally, we should avoid to open the endometrium. But endometrium is a dynamic structure. Otherwise, also it shades off every month. If it is open, you have to suture with 2-0 Vicryl, and then over that you have to suture the. Don't take endometrium along with the myometrium. That should be the trick. You can suture endometrium, or few people just leave it like that. So,
yes, Dr. Pandit Palaskar, I want your opinion in this. I think here Dr. Harshad can also answer if there is any extra comment, or we move. I think Dr. Manjushri, you have asked very well, and we can go ahead with the next question now. Thank you. Can I get the next question? Dr. Gurpreet,
yes.
Yeah, you can read your question, please. Go ahead.
First of all, I would like to thank you for having me here. Am I audible?
Yes, madam. Yes.
And I'm in awe with the way you do the presentation, sir. And I really appreciate the way you conduct the webinars. And it's so knowledgeable. And thank you very much for inviting me. So my question is, Miss LMN, a 24-year-old unmarried woman, has a history of severe pelvic pain since the last 6 months. On pelvic ultrasound, she had a right adnexal mass of 4 by 3 centimeter diameter arising from the left ovary. It had a well-defined smooth border and a wall thickness of 4 millimeters. The center of the mass showed a ground glass appearance. The patient is not willing for surgery. So on the basis, the questions that are put up are, first question is, what is your diagnosis? So on the basis of ultrasound report, it says that there is a well-defined smooth border and ground glass appearance, which goes more in favor of ovarian endometrioma. So the standard transvaginal ultrasound, if you are very well versed with it, the moment you put in the probe and see the visualize this ground glass appearance, you actually come to the diagnosis. So it is usually not MRI is not required, but yes, in certain cases to confirm the diagnosis with another modality of investigation, I would go in for MRI. That is more specific for endometriomas, and the patient requests you to avoid surgery as far as possible. Looking at her age, she is just 24, she is unmarried, and she just has got pain, severe pain, and that's all. So we will not go in for any sort of surgery at the moment. Her complaint is regarding pain, so that will be sorted out with good painkillers, NSAIDs can relieve the pain. And what we would be the most effective medical management for her. So, in line with the medical management, we have got various drugs like NSAIDs, and apart from NSAIDs, Dynogest is a very good molecule, and it has got multiple roles, like it is also anti-inflammatory, anti-proliferative, and anti-androgenic. So it has got given good results, in stopping the progress of the endometriosis. So I would go in for Dynogest as a good medical management, apart from giving NSAIDs to relieve her pain. So what happens is, and in young women, endometriosis can be described as Mona Lisa face, where a mysterious smile covers a hidden disease that tragically threatens to destroy the perspective of a healthy reproductive life. So our main aim should be to improve the quality of life in these patients. And how often do you want to monitor? So initially, I think so with NSAID and Dynogest, I would give her time for around 3 months, and then I will call her for a follow-up, and we can do her ultrasound and see whether the lesion has reduced in size. So that is how I would like to proceed for this patient. So in this age group of 24 young women, we should never ever try to go in for directly for surgeries. Instead, always our aim should be medical line, and surgery is only for those who are having deep infiltrative endometriosis, or the pain is not relieved by medical line of management. Then and then only we will go in for surgery.
Yeah,
So,
Anna, thank you, Dr. Sandhu Gurpreet. Can I have the next slide? Yeah, Dr. Manjushri, please, you can read your case.
This 34-year-old married woman with AMH of 1.8 came to the clinic with complaints of infertility. Ultrasound showed 4 centimeter endometrioma. I hope it's unilateral, and has undergone 3 IUI cycles which failed. She wishes to conceive. All other hormonal tests are normal. Husband semen analysis shows mild oligospermia. How would you like to manage this patient?
Yes,
sir. In this patient, she had undergone 3 IUI cycle which has failed. She has husband semen analysis showing mild oligospermia. So another factor for infertility is also there. And thirdly, main important is a 4 centimeter endometrioma. So my line of management will be now going for IVF. And her AMH is like on lower side, it's 1.8. So definitely her ovarian aging is also there, and AMH low because of endometrioma, we should go for IVF cycle. And in this, if suppose this size is 4 centimeter, we can have a pickup and transfer same setting. But suppose endometriomas are very large in size, like 6 and 7 centimeter, 8 centimeter, or which is maybe coming in the way, we may have to have a segmental IVF. Segmental IVF defines as first you go for IVF, you do a pickup, you prepare embryos, you freeze embryos, go for laparoscopic surgery, do a endometrioma resection with excision, cystectomy and cyst wall removal, and after that you can have a frozen and thaw cycle for her.
Yeah, thank you so much. Wonderful presentation. Next, Dr. Rohida Chavan, please go ahead. You unmute your mic. Thank you.
Thank you, Niranjan. Included me in the panel discussion. I have given the case, which is a 28 years female, the old female patient married since 2 years, presented with intense pain in hypogastric region, and left iliac fossa for 7 days. History is a chronic pelvic pain related to menstrual period for 1 year with worsening of symptom in the last 4 months. In physical examination, normal vital signs, no fever, flat abdomen, presence of bowel sounds, pain at deep palpation of the hypogastrium and left iliac fossa, and absence of peritoneal signs. Vaginal examination shows retroverted uterus, fibroelastic colon, intense pain at uterine mobilization, at palpation of posterior and left lateral diaphragm, left adnexal mass palpable, tenderness present, around size is approximately 5 to 6 centimeter in size, felt separate from the uterus. Pelvic ultrasound finding is also given that normal size of uterus with small quantity of free fluid in the uterine cavity and left adnexal endometrioma measuring around 5 to 6 centimeter. In this case, basically, it's a endometriosis, but ultrasound finding clearly mentioned here that is endometrioma is of 5 to 6 centimeter. Usually said that fibroma is less than 4 centimeter, like 2 centimeter, 3 centimeter, doesn't interfere with the pregnancy or conception. But endometrioma size more than 4 centimeter, then patient need surgical management. Surgical management means it's a combined technique laparoscopic, that is a cystectomy with removal of fulguration of the spot and removal of the cyst wall also. That is only a recent acceptable method of treatment. In that, patient will be free from the pain, as well as the better chances for conception will be increased. I think that is the baseline of treatment is given.
Next slide. Yeah. Sana, what will be the diagnosis and management approach?
Question is that what will be the diagnosis and management approach? Just now I told for the diagnosis, basically any endometriosis cases, history is very important. Then clinical examination is the most these things, and supportive method for the diagnosis, ultrasound will show the quite better idea what is the diagnosis. Sometimes MRI also can be done for the diagnosis. The next question is that what will be the role of diagnosis? Diagnosis basically progesterone, which is basically decrease the pain and improve the quality of life. Available in the 2 milligram, that can be given long time treatment. It is maybe 1 year and like more than that also. Which improves the chances for the conception as well as the symptom free. And then GnRH agonist and antagonist, both are the same. These things, GnRH agonist, antagonist, which directly suppress the luteinizing hormone and follicular stimulating hormone and directly decrease the estrogen. And estrogen is basically responsible for the endometrial development. So it reduce the pain and the chances for the pregnancy. And agonist has the effect on the basically decrease the production of the estrogen.
What will be the laparoscopic management?
What will be the laparoscopic management? Just now I mentioned about the laparoscopic management.
Sana, please start the video.
Medical line of treatment. I told you that if the size of the video is shown here, you can observe the size of management of the endometrioma. In that, basically the laparoscopic management, in that incision is taken on the endometrioma below this, and that content is a chocolate material is removed and aspirated.
So here you see that the cyst wall is peeled and there is a traction and counter traction. There is a Maryland and a grasper, and we are using the suction cannula.
Simultaneously,
The
because
suction
in the
cannula tip
endometrioma, it's very difficult to remove the cyst
with
wall
the plate.
separately. So they are trying and removing the cyst wall, so it will be not recurrence will be can be reduced. Otherwise, the recurrence in endometrioma is after 5 years it can be there.
Proper instrumentation is also very important.
Yes.
Tooth forceps is to be made use of. Otherwise, you just end up pulling the
while
ends
removing
out.
the cyst wall. It's a little bit difficult. It is with patience.
This is
If you
actually
keep
a very
on
lucky cyst
removing
wall
this
which
wall.
came out.
Yes, madam.
You should get the proper plane actually, and then things become easier.
What do you feel the use of pitrescine?
Yeah, that really helped, but not in
I'm
the
not
cyst
audible
wall.
basically.
To get the proper plane, we don't require actually.
Not in the pitressin, not in the cyst wall, but definitely if we use pitressin, it makes life very easy. It becomes an avascular plane and you can work very nicely on it.
Yes, so you can see now we are using CO2 laser.
Yeah, CO2 laser is being used.
Excess use of energy
Am I
source
audible,
is
sir?
not recommended.
Yeah, sir, you are audible. Sir, you are audible. Chavan, sir, you are audible.
We can hear you. So this is how you do. Wonderful laser which has been used, and the whole area is cauterized. The whole idea is that you should see that the AMH is not reduced, the ovarian reserve is kept. You only do minimal cauterization, do not jar the ovary. And the idea is that wherever hemostasis has to be done, you can use laser or you can use the tip of the bipolar cautery. And that's what we are using here. And gently just see that the hemostasis is achieved.
In this basically modified laparoscopic surgeries used, because only ablation is also destructive to the ovary, or only cystectomy is also destroy the ovary. So the baseline of method is the combined modified laparoscopic technique, that is a conservative to conserve the ovary.
Pre-op
This is the
evaluation,
management for the endometriosis.
pre-op evaluation regarding the levels of AMH is also important, and counseling regarding this kind of.
I'm not audible actually.
No, we can hear you, sir.
Counseling of the patient is also very important because such extensive surgeries post-op AMH values can go down. So proper counseling also plays a very important role in such a big endometriosis.
Yeah.
That's true. But AMH don't just jump on doing it immediately post-month.
You are not audible, madam.
I'm not audible? Am I audible?
We can hear everything.
Not audible.
Okay.
No,
So AMH, it is
Dr.
said
Rohidas,
that
you will have to, there is a button on your laptop, you have shut it off. Otherwise, we can hear you. We are able to hear.
Yeah, you can you hear me?
Yes. Absolutely, we can hear.
So I was just saying that immediately don't rush for AMH in the next cycle. Wait for at least 3 to 6 months and then get a AMH level done. So that will be a better thing. We will get the perfect report also, and AMH improves also. It is not that immediately post surgery it will drop down, because AMH is being produced by all antral follicle. Antral follicles don't get cauterized. Am I audible?
Yes, very nicely audible.
So like AMH is produced by all antral follicle. So immediately post surgery, if you do in a month's time, all antral follicle you are ought to get it cauterized. If there is a bleeding, you have to have a hemostasis. whatever delicately you will try to do, you are going to decrease little bit of AMH. But the next lot of antral follicle, which will come maybe 3 months or 6 months down the line, it will have a better AMH reporting. So, like, definitely counseling, I agree 100% that you have to say that AMH is going to drop, but don't immediately rush and be in tension for yourself and for patient. Give her time to recover from antral follicle, and maybe 3 months time, or maybe down the line, if she's not infertile and she had just come for pain, we can wait for another 6 months also. Like a young girl, one case was there, 24-year unmarried girl. Suppose she needed endometrioma surgery, we can ask her that get a AMH, just a routine done after 6 months.
Absolutely. Wonderful presentation by both of you, Dr. Rohidas and Dr. Sandhu, and interesting. There are many questions which are there, but I think Dr. Pandit has dropped out. I think there is some network issue. His number is coming busy, and we have got questions which are there. Uh, Dr. Manjushri Boob, I would like to ask you a question. You were saying about some investigations. So you have a endometrioma case. Have you seen a case of endometriosis with fibroid? Obviously, there are two concomitant pathologies also can be there. So in that circumstances, you have a fibroid also and an endometrioma. Dr. Rohidas Sawan said that proper peeling of the cyst wall has to be done, because if you do not do, the recurrences occur. And similar things happen in a fibroid also. If you have got say 4 or 5 fibroids in a given situation, and if there are seedling fibroids, then it is embedded, say it is intramural and it is out of the incision. What happens is after 1.5 to 2 years, that small fibroid which is left out, it grows, and again a repeat laparotomy or a laparoscopic myomectomy has to be performed in such cases. And similarly, if there are small endometriotic cysts which are there and they are not removed, they grow further, and then you have not only recurrence of that present surgery of what you have done, but actually it is a small endometriotic cysts which are left out, and they every month there is the internal bleeding, and as a result it becomes enlarged. So the patient feels that even though you have done a surgery and total removal of that cyst wall has been done, but it is something like an incomplete surgery. Do you agree with me, or you have a different take on this?
Sir, for like, there are two questions in it. One is about fibroid. You are doing a myomectomy. So before doing a fibroid surgery for laparoscopically, you should have a fibroid mapping. If you don't map a fibroid, and see, fibroid, all fibroid don't cause infertility. So fibroid which is hitting or compressing the endometrial region, then submucous fibroid we need to remove. If you have multiple fibroid, you said, like few small tiny fibroid which are subserosal, that time only we may leave it, because we may have to have a cut short the time of surgery. So, like, removing every small peanut fibroid may not be, if she's a infertile, I'm talking of infertile patient. So all small subserosal or serosal fibroid you may not taken into account, but you have to write on your notes and tell that patient very correctly that this was the mapping which was done pre-operatively, intraoperative findings are this much, and maybe this small fibroid which I had not removed, or you can pass it in a gentler way that this was not needed to remove at this time because of length of surgery or for any reason if it has kept. So that should be mentioned on the paper. And after that, if she comes out, she exactly knows that my 2 fibroids were there in subserous region and size was only 1 by 1 centimeter. So might be they have grown afterwards, because this seedling fibroid may grow after 5 years, 10 years. So we have to be very precise. And secondly, for endometriosis also, if she is not for infertility and you have done chocolate cyst, it's always better to get, like a young unmarried girl with a endometriotic surgery, you had found that few spots are there, it's always good to excise those. But suppose we are not excising, or it is a recurrence, we can put them on Dynogest for pretty long time if they are not planning a pregnancy. But if she is infertile, then life is absolutely different. Then we have to plan in a different manner. We have to immediately take her for IVF cycles then. if it is stage 3, stage 4 endometriosis, they are good for IVF.
Yes, yes. Doctor, thank you, Dr. Manjushri. Nice discussion. And we have our whole panel is on fibroids and endometriosis. And it's sometime, the fumbling fibroid is now trembling in our hands and it is going to vanish away. That is the reason we have kept such a wonderful titles. Though it is fumbling, but it is trembling now because when we are operating them, it is going to be very important that we do not want any repeat surgery, and that's what happens when you have a patient coming up with a repeat endometrioma being formed. And I will tell you, I have operated a patient with myomectomy coming from abroad. I don't want to say, but I had to literally open every time because 2 to 3 times I had to open her actually, and then it becomes very very difficult. First, I did open surgery. Second, I did a laparoscopic surgery. Third, also I did probably it's an intrinsic something related to the estrogen hormone, and they are sometimes they are some like some women are more prone to have an excess of keloid or scar formation as compared to a woman who has a very thin, slim scar and it is not seen. And the surgeon is you're the same person, your technique is same, but the response of the body is totally different. So I think it's very important that you have to do proper counseling, a consent has to be taken. Dr. Gurpreet, I'm coming to you now. As you know, laparoscopy is a gold standard for endometriosis. But at the same time, when you put in a scope, do you feel that on an ultrasound picture, you just see a tip of an iceberg? But actually, when you put a scope, it is seeing is believing, and that's what they say about endometriosis. So, what do you feel? So, when you are going to do a surgery, which is for, say, endometriosis, is it only a diagnostic test or you are going to take a consent beforehand for any operative procedure? So how do you manage such cases? Because once the patient is under anesthesia, it becomes little difficult to go back and try to explain. I'm sure this is a very, very important question, and that's the problem where we should not come into.
I would start with saying that the first surgery should be the best surgery. The patient should not be put to repeated surgeries. It could be very distressing. So I feel proper history taking and proper evaluation, getting the proper investigations done, even if you require, sometimes many of the gynecologists, they prefer doing their own ultrasound. But while doing so, you might miss out with certain, lesions. So it is always better to get proper investigations done. If you're not confident enough, you get expert opinion. And after evaluating the patient, counseling her again and again, explaining her about the lesions, what could happen later on, about the complications according to the recurrence, which is very high in endometriosis, then only we should go ahead. And if they're agreeing to all these after knowing all these complications and what are the problems that can come across. And intra-op, yes, if it's a diagnostic procedure, I'm not knowing about the lesions, it is always better rather than getting into the surgeries like cystectomy and doing all that, ablation of the lesion and conserving the ovarian mass is very important. It should not happen that we go in overzealously and operate on the patient's ovaries and at the end we get the reserves are decreased. That again will hamper her future chances of getting pregnancy. So all these things are to be taken into consideration. Yes, if the lesion is a big size endometrioma, then obviously there is, at the same sitting, we should do proper cystectomy and, I feel that would suffice. That's my take on it.
Absolutely. That's the best line, and that's exactly what Dr. Charmila from Trichy and Dr. Kurian from Chennai also said day before when we were discussing on this intricate matters of endometriomas. So you are on the right track, Dr. Gurpreet. Well said. I'm really amazed
One thing I want
by.
to add, and one more thing I want to add is, if you're not good at something, you should leave the person alone. I mean, don't jump, over seriously. Don't try to do something which you are not confident about. You have your seniors with you, like we have Dr. Niranjan Chauhan sir with us. So these experienced surgeons are also very important. You should know the subject very well, and then only, because you are messing with the things. If you are again and again opening the patient, and it becomes very distressing for the patient to get under the knife. So I feel, as if I keep myself in the patient's place, I need to go for repeated surgeries. That will be really problematic.
Thank
Yeah,
you, thank you.
seriously, it is a messy disease and don't mess up with the surgery. That
Yes.
is the take on it. It's already a messy disease.
Hello,
Yes,
hello,
yes,
hello. Am I audible, madam?
Yes, sir.
yes,
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 sir.
sir.
Basically, endometriosis needs experience for the diagnosis, because many of the times in the OPD, junior person are in the, I am working in medical college, junior person, they never face or never across to the endometriosis. Usually the typical finding and history, if somebody is expert, definitely they can clinically
Definitely.
diagnose endometriosis very well, and then supportive can be done sonography. Otherwise, if person is not aware about the finding, then he will say that it is a PID, something else, and then it doesn't have importance about the retroverted nodularity felt in the posterior fornix. History is very important. Painful, this thing, defecation, menstruation, yeah, intercourse, and like that.
History, investigations, consent, everything is very important, sir. Before taking the patient in the OT,
Yeah.
all this workup, if it is done in if you follow a particular protocol, then you don't land up in any problem as such. And even the severity of the disease, asymptomatic patient might have a very bad pelvis when you open her, and a patient who's got enormous big size endometrioma may not complain of anything. So it is contrasting, looking at the disease, how the patient presents. So variable presentations are there, and best thing is, it should be first surgery, and in the best of the surgeon. That is what we would advocate.
Thank you, Dr. Gurpreet. I'm happy to hear that, and the fact that you have been very well guided by your teachers and your mentors. All the best to you. Good to hear from Dr. Rohidas some salient points, and Dr. Manjushri Boop. It was very nice, absolutely great scientific deliberation and the case presentation which you have done, and we have really enjoyed this Sunday evening with all of you. I
At
thank.
the last, I would like to pass on my heartfelt thanks to you for giving us this opportunity, sir. Thank you so
Absolutely
much,
great,
and
absolutely
wish
great.
you great future ahead, and
Thank you.
not only in upcoming elections, but in life also, sir. Wish you
Thank
good.
you, madam. And I find my
Hello, Niranjan.
house
Hi,
surgeon and
Niranjan.
registrar, Dr. Varsha
Hi.
Rathod.
As an audience, I would like. Hello.
Yes,
As
yes.
an audience, I would like to congratulate you. It was a very nice session, moderated very well, and very nice cases on fibroid and endometriosis. So it
Thank
was a
you.
very real, nice discussion.
Thank you, Doctor.
Congratulations. Nice to see you.
Yes. I'm also happy, Dr. Varsha, because nowadays we can't meet in person. But I want to just tell that Dr. Varsha Rathod was in Mumbai in 1990s when I was a registrar and she was a student of my teacher, Dr. PK Shah sir, and we were together for 3 years. And that time I recollect Dr. Rohida Chavan was also doing his residency, I think in Wadia Hospital to be more precise, and that's how our relationship is going. Later on, they travel to Yavatmal and they have a big setup there. He was also the past president of Yavatmal, and I'm sure this is the way we are connecting Dr. Gurpreet from Aurangabad and Dr. Manjushri Boob, Amravati, and we had Dr. Pandit Palaskar today coming up and giving his valuable time on tips of doing a sling surgery, when to do anterior surgery, when not to do an anterior or a posterior surgery, how to delineate the pectineal lines. All those questions which have been there have been answered by him in this presentation. There is nothing to be worried about. You will get this recording in the next 2 days' time, and I'm sure I will send you those recordings, and you will be hearing Dr. Harshad Parasnis once again, endometriosis with cancer, and Dr. Pandit Palaskar, and the beautiful panelists which we had today. I thank Dr. Sanjay Gupte, Dr. Suchitra Pandit, and Dr. Mandakini Meg to be there, along with Dr. Kanan Yelikar and Lakshmi Shrikande Madam to give their valuable time. I would also like to thank the presidents, Dr. Vaidya Marathe, the secretaries of the societies of Aurangabad, Nagpur, and Amravati who have joined us today. I would also like to thank our chairperson of Female Breast Committee, Dr. Snehar Buyar, who had joined us with us, and she has spent her valuable time. Give my regards to all of you in Yavatmal, Amravati, Aurangabad, and Solapur. And I would also like to thank Dr. Kiran Sharda from Solapur and her team to join with us. And please be safe and take care. Yes, Dr. Gurpreet.
Yes, sir. I would go on board and say that you are the best anchor. I mean, compare your skills and you're impeccable. I mean, I feel like comparing you to Arnab Goswami and Shashi Tharoor. I mean, you are just great, sir. And the way you attract this crowd, and you have this TRP of 1,000 and 5,000 people attending your webinars. It's just awesome, sir. So thank you so much for having me.
I also second the same. I also second the thought of Dr. Gurpreet Kaur.
Thank you.
Your moderation is simply superb, and hundreds you have done.
Thank you, madam. And I would also like to take this opportunity to thank Bharat Serum for doing this program, bridging Bharat, Elusive, Endometriosis, and Fumbling, Fibroids. Today, fibroids are trembling, and endometriosis is no more elusive. Thank you so much. Take care. Shubha Khair, Shubharatri. Good night.